Thank you very much. So, after going through this much extensive discussion about this management of thyroid cancer, where the role of oncologist come, when you think that the tumor is now radioactive iodine refractory and not a feasible candidate for further radioactive iodine therapy, so you can switch them, you can send them to oncologist, or being as a good nuclear physician, you can do it yourself also. It's not so a big rocket science. When to start TKI and which TKI. This is my topic of my presentation today. And you know it very well that all the patient doesn't need TKI. There is certain limitation to start this TKI, and we can observe such patient until unless there is a progression. As per the recommendation, TKI should be started when there is something 20% increase in the tumor size from the baseline after getting the refractory disease. You started with the tumor, and let's see there is some deposit in the lung or there is some deposit in the liver, which the surgeon say it's not resectable. Oncologists say it's very difficult to radiate that area because it's a part in the lung or it's a part in the liver. So, and chemotherapy is not having good effect. We used to give some chemo, doxorubicin, Paclitaxel initially. So what to do then? It's not a recommendation that we should immediately start TKI. We should wait till there is any progression, even if the TG is going high. If TG is going high, but tumor is silent, tumor is there, not increasing in size, the recommendation for increase in size is 20% increase in 1 year. Let's see, if the tumor size was 1 centimeter, now it's 1.5 centimeter, this is something increasing. But if it remain 1 centimeter, I think nothing to worry about this tumor size. Patient, most of the time, when you're referring this patient for TKI, they're asymptomatic. So, if you're going to give TKI, you can make them some symptomatic on the basis of their side effects, rather of having some good improvement of this use of this TKI. So, and also still a good hope for the nuclear physician, even after the start of this TKI, you can have a redistribution of iodine after a certain period of time. I'll show you the data that you can have the redistribution or reuptake of the iodine scan, and still the role of nuclear physician will come again, and we can send them back to the nuclear physician that give another dose of iodine therapy because it is recommended now. I'll show you the picture and I'll show you the data. So what is this TKI? All my those colleagues who are just in the learning phase, students, residents, TKI. If you just see from this simple picture I have put on the front page, this is the cell membrane, and in the cell membrane there is extracellular part of the cell membrane and there is intracellular part of the cell membrane. Both have different recommendation. Extracellular part has different recommendation for the treatment, and intracellular part have different recommendation. You can block this extracellular part with the monoclonal antibodies. When I use the word of MAB, monoclonal antibody, it means it's some drug in the form of infusion or injection. When I use the word of TKI, it means there will be the word in the end of this drug NIB, like sorafenib, lenvatinib, solanezumab. So all NIB will be in the form of oral form. So all NIBs are TKI. So you can block the intracellular domain of any signal through this TKI, or you can further block intracellular domain with some other TKIs which are recommended according to that. So start from all this, you know it very well, the treatment of the DTC, differential thyroid cancer, surgery, iodine, hormone replacement, and limited role of EBRT, surgery, chemo, and all these things. If you just recall your physiology, from very basic physiology, sodium is very important. If you want to take any of the molecule inside the cell, you need sodium. Like if you want to shift one glucose molecule inside the cell, you need 2 molecules of the sodium. Similarly, one phosphate, you need 3 molecules of sodium. Same way, In iodine, you need one iodide molecule to be taken inside, you need two sodium molecule. So this is called symporter of this sodium iodide symporter. When there is some refractory disease to this issue, this blockage or this pathway is blocked due to some reason that it has somewhat now become resistant. As you keep on giving antibiotic, then the cell become resistant to this antibiotic. Same way, iodine is there but not taken up by the cell. So this could be the reason that this symporter is not working. And if you another slide from the iodine is taken up by the cell from the circulation. It is then conjugated and the oxidation there, and then it's formation of T3, T4. It's a very simple phenomenon from the thyroid follicle. 20 to 25% of the thyroid disease, when become metastatic, they are resistant to your iodine therapy. What should be the maximum dose and how frequently you can give iodine? Until unless showing avidity you can give. If it is not, then definitely it's a refractory disease. So if you just see, even if become refractory, still you have a median survival of roughly 5 years plus. Thyroid cancer is the only cancer in our field of oncology where we talk about the 10-year survival. As compared to all the tumor would say about 5 years survival. The thyroid cancer would say it's a 10-year survival. So even become it's refractory, still patient not going to go anywhere. There is high chances. But if you're going to have some iodine uptake disease, your median survival is roughly 15 years plus even now when it's showing the uptake. So it's a very good tumor, and prognosis of this tumor, even the stage 4, is quite good. Now something basic about the immunity and immunotherapy. You know that we have the different cell in the body. Some are called innate immunity, some are called adaptive immunity. In adaptive immunity, we have a B cell which form the antibodies. We have T cell which form the CD4 and CD8. What is the difference between innate and adaptive? Just in one slide. Both have the first line of defense, innate and adaptive. But it is an immediate response. This takes some slow response. It is non-specific. This is specific. Once there is some antibody has been formed, it will remain in the body. It is not taken into the memory cell. This is taken up into the memory cell. This is usually by the natural killer cell, and the neutrophil, this is usually by the CD4 and CD8. In our immunotherapy, in the field of oncology, this is the CD4 which is having the major role in the management of the immunotherapy. And what we do in antigen, in APC antigen, when the antigen inside the body, it is taken up by the APC. APC binds with this your CD8 and form more T cell. Same way in the CD4, it form more T cell. T cells, when it infiltrate into the cell, if you just see, this is a tumor, this is the antigen. Antigen is taken up by the APC, dendritic cell. Dendritic cell takes it to the lymph node where the T cell are rich over there. T cell is activated through the circulation and reaches up to the site of the tumor, and then there is a tumor infiltrating lymphocytes. The cell or the tumor which are having more TIL, they are having good prognosis as compared to having low tumor TIL. So tumor rich in TIL then going to take up this tumor. Now, how the TKI going to take up? When there is extracellular domain, we have monoclonal antibody. For the intracellular domain, we have different receptor like VEGF receptor, vascular endothelial growth factor receptor, platelet derived growth factor receptor, EGFR, RET receptor. They are all in the intracellular domain of the cell membrane. But in the within the cytoplasm, we have different domains, and we have the BRAF, MAC, c-KIT, mTOR, ALK, PIK3, all these are the mutations. So if you block this pathway, you need some inhibitor, you need some drug which can block. If you can't block these signals, there is more proliferation of the cell, there will be more angiogenesis, there will be more neovascularization, so there is going to have a more tumor cell proliferation. So you can block by using some TKI at this level, or you can block some using TKI at intracellular level. So in this way you can better control the disease by blocking these signals. If you just see this one, if this is a rat PTC mutation over there, and it's going to activate the RAS pathway. RAS pathway includes this BRAF, NRAS, KRAS, all these different pathways. RAS is going to activate BRAF, BRAF is going to activate MEK, MEK is going to activate ERK. When this pathway or cascade is signaling is there, tumor cell will be keep on growing. Or you can activation of this RAS, this can activate the PIK3CA pathway, which is going to act on the AKT, and AKT is going to act on the mTOR. We have the drug against mTOR, we have the drug against PIK3, we have the drug against BRAF, and we have recently started the drug with the ERK also. So these are the different drugs coming, but they are going to act on this level. If you can block this RAS by any mean, we have the drug with the lenvatinib, we have the drug with the cabozantinib, we have the different drug. I'm going to give you one by one. You can stop this blockage also at the vascular level, so that there is no new vascularization. You can block this VEGF receptor pathway. You can block this fibroblast growth factor receptor. You can have different drugs against available. In thyroid, specifically in the thyroid, these are all receptors which can have overexpression. If you can detect that this overexpression is there or not, you can treat in a better way. But if you don't know, or if these tests are not available, then the simple one, start any anti-angiogenic multi-kinase pathway. I'll give multi-kinase inhibitor MKI, which can be used against like many other receptor blocker. If you just see this one, this was the famous drug we used to give, the sorafenib. It is MKI. This can block the VEGF receptor. This can block the PDGFR. This can block KIT. This can block react the FLT also. So it is MKI. Sunitinib, axitinib with the name Enlita, sunitinib. So good drug for the management of medullary thyroid, for the renal cell carcinoma. All these drugs are plus minus available by different means. No, and the drug which is available, and I'll show you the data also, which is effective against many receptors and available also, registered in Pakistan also. We can use this one, is with the name of lenvatinib. Okay, so lenvatinib can be used as a anti-MKI. If you just see this one. So we have the very famous trial with the name of SELECT trial. So lenvatinib, sorafenib, cabozantinib, axitinib, or solomatinib, these are all TKI, which is somewhat available in different form, with different ways in Pakistan, but the registered one is the lenvatinib and the sorafenib. We are using the lenvatinib, and the dose of the lenvatinib is quite high in thyroid as compared to the other tumor. This was the SELECT trial, and if you just see the SELECT trial, when it was compared with the placebo, there is a HR ratio 0.21. 0.21 is quite significant HR ratio, and there was a difference of 3 versus 18 month median progression-free survival, roughly 1.5 year plus median progression-free survival in all those patients who were refractory to your iodine therapy. So lenvatinib with the dose of roughly 24 milligram, usually we give 8 or 12 milligram, 24 milligram, you can use 10 milligram one capsule and 4 milligram one capsule. This is the DECIENT trial, and here they compare the sorafenib with the placebo. This is the difference of 5 versus 10 month. Same way, if you just see, it's not easy to use. If you're planning to start yourself as lenvatinib, must check the 44% grade 3 hypertension rates is there with the lenvatinib. Grade 3 hypertension means that their blood pressure can go up to 160 millimeter mercury plus with the lenvatinib. So if the patient already having hypertension, you have, it's not as a contraindication, but you can have a good control of the blood pressure. All other side effects are plus minus. If there is a Vendatinib phase 2 trial with the name of Caprelsa, good drug for the medullary C thyroid, this can be used, and this is a difference of 5 versus 11 month. If there is a failure of this your Lenvatinib or Sorafenib, then this is Cabozantinib. This trial has recently, yesterday has been published or presented in the ESPO 2023 in Madrid, Spain, and they have used the Cabozantinib against the different physician choice drugs, and they have good response. Cabozantinib with the name of Comitrex, it's available. It's being used for the many other tumors like renal cell carcinoma also. And even if there was a progression on this Lenvatinib and Sorafenib, you can have a further improvement of roughly 5 to 6 months with the use of Cabozantinib. Now, these are the different drugs. If the anti-RK inhibitor, you have to give Entrectinib with the name of Roslitric or Larotrectinib with the name of Vitracvi. Same way, if the PTC in oncogene inhibition, we have Selpercatinib with the name of Retivmo or Preseltinib with the name of Gavrito. For BRAF mutation, we have Vemurafenib with the name of Zelboraf and Dabrafenib with the name of Tifinler. And the same way for PIK3 inhibitor, we have the Everolimus, or we have the name of Alpelisib with the name of Picre. So these are the different drugs which can be used according to their mutation, and you can see their response roughly is around 50% plus. But these mutations should be there. If these mutations are not there, then these drugs may not be so. So for generally, for when there is no mutation, then Lenvatinib is a good option. But be careful when you're going to ask for any anti-angiogenic MKI like Lenvatinib or bevacizumab. There should be no surgery within 28 days. There should be no active bleeding. There should be no brain hemorrhages. There should be no carotid encasement. There should be no any thromboembolic event in the last 6 to 12 months. Response evaluation after 2 to 4 months. There is no role of FDG PET in the radioactive iodine refractory disease. Rather the PET which is recommended, that's iodine 124 PET which is recommended, not FDG1. FDG PET can be done in this medullary anaplastic, another one, but not in this. Redifferentiation. Redifferentiation is possible, especially when there is a BRAF mutation is there. And you can see these were the patients who were treated with the initially iodine, then become refractory, and then they were, when they were given this Solumatinib will come with the name of Crisivo, I think. And there were further redistribution of this iodine, and they responded with same way. This was the Leon, not iodine uptake, but with the Solumatinib there was uptake again over there. So there is a redistribution option there in such patient. So this is my last slide. This is a quite jumbled slide. You can say the final conclusion of this slide is that if you have an option for NGS sequencing, as has been started by the PINAM, you can ask for the target mutation checking or the 27 gene panel or NGS, which we are going to start soon with the Dr. Shazia Fatma has started this NGS sequence, which is the third generation, first NGS in Kiran Karachi. We have started the BRCA testing, and soon we're going to start the whole genome sequencing also, inshallah, in Karachi. You can send or you can start this patient checking their mutation level, whatsoever is mutation is there. Even you can check the TMB level, you can check the MSI level. If they are there, you can start with the pembrolizumab also. So if you don't know anything, any mutation, start with the Lenvatinib, which is going to have a good 1 year plus progression-free survival. If not, then if Lenvatinib is not available with you, you can start with the Sorafenib also. So these patients remain very well on this cure management. I think this was the last slide. Thank you very much for listening.